It really has been a wonderful couple of days, and I feel privileged to be here, and I feel particularly privileged to be here with you all and with the patients. And I wanted to congratulate and really applaud Drs. O'Donnell and Axman for really adding this to a session like this. I think having people here. And after all, if I was a patient and I heard somebody talking about me, I'd want to know what they were saying. So it's wonderful. So my job is to talk about, I have Pseudomonas aeruginosa infection, and what are my options? So I think I should start with what Pseudomonas is. It's obviously a bacteria, and we refer to it as a gram-negative rod, particularly because of its shape, and you can see it on the right-hand side of the panel, and because it takes up a certain stain that distinguishes it from other bacteria, and this is a classic piece of microbiology. Now, we've gotten a lot more sophisticated in identifying some of these bugs, but it really is classified classically as a gram-negative rod. Now, there are other gram-negative rods that can cause infection in patients with bronchiectasis as well as other diseases, but Pseudomonas is the one we focus because it's the most important and the most common bug that we see. Now, like a lot of the bugs that we've talked about in this conference, it's actually common in the environment. You find it in soil, you find it in water, but it typically does not impact otherwise normal, healthy people. It's an opportunistic pathogen, and it takes advantage of circumstances like those who have abnormal lungs, those whose immune systems are impaired, or those who were previously healthy but are now very sick in the hospital or the intensive care unit, which puts them at risk for this infection. Now, the data has shown us that about 30% of our patients with bronchiectasis will develop a chronic infection with Pseudomonas. So why is it that patients with bronchiectasis develop Pseudomonas infections? Well, I think there are lots of different reasons, many of which are complex, but I really think that Pseudomonas takes advantage of two things. One is the anatomic problem, the typical and key anatomic problem of bronchiectasis. Bronchiectasis means permanently, or it means enlarged bronchial tubes, which are permanently enlarged. And in concert with that is impairment of the movement of mucus and bugs from the lower airways to the proximal airways. And what you see on the right-hand side is a bronchogram. This is the way that old-style physicians used to make the diagnosis of bronchiectasis before the days of CAT scanning, but it really gives you a very nice representation of the dramatic changes that occur in the airways of patients with bronchiectasis. And if you look at what a bronchiectasis patient looks like, this is a patient with severe bronchiectasis. You see these hugely enlarged bronchial tubes that don't taper as they go from the middle of the lung to the periphery of the lung. And on the left-hand panel, you see that yellow mat of material. That's actually a very enlarged bronchial tube, and that's a perfect environment for bacteria to set up shop, and also an environment where it's very tough to deliver antibiotics to those areas. So the anatomic defect of bronchiectasis is a key reason why Pseudomonas is such an important pathogen. And the other is inflammation, which is also a very important part of the development of bronchiectasis. And this is from a paper that Dr. McShane and I wrote. And this is what a bronchial tube looks like under the microscope. On the right-hand side, you see a normal airway, and you see the little hair-like structures. Those are the cilia. There are a lot of them, and they are straight. And then you see relatively normal and bland-looking epithelium and areas that are below the surface in the airway. And if you look on the left-hand side, even on gross view, even without a video, you can see that the cilia of a patient with bronchiectasis, they're sparse, and they look abnormal relative to the normal panel on the right. And there are a lot of blue round things in the airway compared to the normal patient. Those are inflammatory cells. They happen to be lymphocytes. And the pathology and the inflammation of bronchiectasis is pretty complicated, but you can see that inflammation, impairment of ciliary function, and the bronchial tube enlargement are really the reasons why our patients get chronic infection with Pseudomonas, as well as other bacteria, including NTM. Now, there are a number of reasons why Pseudomonas aeruginosa is very challenging to treat. One of it is intrinsic properties. It has very low antibiotic susceptibility because of its intrinsic antibiotic resistance mechanisms. The other thing that Pseudomonas can do is form biofilm. And there's a very sophisticated medical term for biofilm, and it's called slime. And that's what that is. It's slime that sits in the airway. It's a very complex matrix of material and protein where the bacteria live, and it makes it very hard for antibiotics to penetrate into this biofilm. And this is a very important concept and one of the challenges of treating patients with bronchiectasis. And it is a bug that can induce and propagate inflammation, and really propagates that vicious cycle that you've heard a number of times already today. Now, why do we care about Pseudomonas? Well, it's associated with frequent exacerbations, and I'll come back to this in a second. Clearly, patients who have Pseudomonas have a worse quality of life. They tend to be hospitalized more frequently than those who have either no dominant bug identified or other pathogens that are not gram-negative rods, that are not Pseudomonas. And there is some data that suggests that patients who have Pseudomonas infection, as well as other markers of severe disease, actually have a higher mortality. So this is a slide I've shown before, and really just to highlight the impact of quality of life, or on quality of life, for patients with bronchiectasis. So this is the St. George's Respiratory Score. This has been used for years in a number of respiratory diseases, and the thing that you need to know is the higher the score, the worse the quality of life. So if you look at the left-hand side, patients with bronchiectasis have impairment of quality of life that's akin to other more common and yet severe diseases like moderate or severe COPD, people with idiopathic pulmonary fibrosis, which is a scarring disease of the lung. So it's very clear that this is a very impactful disease. But if you take patients with bronchiectasis and you look at those specifically that have chronic Pseudomonas infections, their quality of life is even more severely impaired than other bronchiectasis patients and other patients with different forms of lung disease. Now, we talked about an exacerbation. This came up in a previous session and in previous questioning. So let me tell you what an exacerbation is. And it turns out that you know what an exacerbation is and you know when you're experiencing it. And I, as a physician, I think I can identify it when I see it, but it turns out that it gets very hard to define, especially when you're trying to do clinical trials and do research in this area. So this is a definition that a number of us in the room, a number of us at this conference developed last year in a consensus fashion. And we did it specifically to use for using it as an endpoint for clinical trials, but I think it's clinically useful even in an office setting between you and your physician. So an exacerbation is a person with bronchiectasis who has a change or a deterioration in 3 or more of key symptoms for at least 48 hours. And these include cough, the volume of sputum and its consistency, the thickness of it, the purulence of it, and the association with other systemic symptoms like shortness of breath or exercise intolerance, fatigue or malaise, or the expectoration of blood. So it's a change in those signs and symptoms accompanied by a physician or provider's decision to change treatment. And that includes antibiotics, but is not limited to antibiotics. So again, intensification of bronchial hygiene and airway clearance alone is an intervention, and that's part of the definition of an exacerbation. Now, exacerbations are something we pay attention to because we think that those who have frequent exacerbations have a more rocky course than those that have occasional exacerbations. Now, we spent a lot of time in this conference talking about different causes of bronchiectasis. Well, another way to think of bronchiectasis is not based on its underlying cause, but based on a group of symptoms or characteristics that are in common despite or in addition to the typical kinds of underlying diseases. So Dr. Chalmers, who I think is still here, really did a brilliant job in this paper that was recently published in over 2,500 patients from both Europe and from Israel. And this bespeaks a couple of important points. Number one, how heterogeneous the disease is. So 40% of the patients in this research trial had very infrequent exacerbations. Some had none, and some had 1 per year. But 40% had 3 exacerbations or more, typically ones that got antibiotics. So what we know is, and what we've learned, is that people who have had exacerbations in the past and have had frequent exacerbations, those are the ones that are more likely to have frequent and severe exacerbations moving forward, and that's a very important piece of information. Now, there are a number of predictors for those who have frequent exacerbations, and I won't go through those in any detail, but you can see that infection with Pseudomonas is one of those independent predictors, and frequent exacerbations, those who have frequent exacerbations have worse quality of life, they have more severe disease, and again, increased mortality. And that's why we pay attention to not only those who have infections with Pseudomonas, but those who have these frequent episodes of exacerbations. Now, I'm not going to go through this vicious cycle slide. I've seen it 3,000 times, and I can't do it. But what I'd like to use it is to really frame the treatment approach. And I will make this point more than once. Treating an infection is more than just using an antibiotic. So clearly, the mainstay of treatment is antibiotics, both systemic, that is by mouth or by vein, or inhaled. But we have other things that we can do. So we've talked about inflammation as an important part of this disease. So we have some information that another antibiotic or another group of antibiotics called the macrolides actually have some anti-inflammatory properties and properties that modulate the immune system that can be very helpful in patients with bronchiectasis, particularly those with Pseudomonas. Again, we had a wonderful talk by Dr. Daniels about airway clearance. That's a critical part of the treatment of bronchiectasis and those who have Pseudomonas infections. Won't talk about surgery a lot, but there are options to deal with patients who have a rocky course, and that can include surgery in very limited numbers of patients. And then finally, when we identify an underlying cause that we can treat, again, treating that underlying condition is a very important part of what we do for you and patients like you. So I'm not going to spend a lot of time talking about this, but airway clearance is a critically important part of the treatment of patients with bronchiectasis and Pseudomonas. And it refers to a bunch of techniques that are designed to enhance the movement of sputum from the lungs. It's like getting the ketchup out of the bottom of the ketchup bottle, right? That kind of stuff, and moving it towards the front. We think of it, and I think this is really universal, both in the United States and the United Kingdom and all across the world, it's considered a mainstay of therapy. But unfortunately, there's not a lot of research to prove that in an unambiguous way. So there are a number of modalities that are in use, some mechanical methods. We've talked about some drugs, including hypertonic saline. The vibratory PEP devices, which you can see here, are the most commonly used in the United States through the U.S. Bronchiectasis Research Registry. But importantly, only about 56% of the patients in our registry were on airway clearance, and that's, I think, woefully inadequate moving forward. There are also these high-frequency chest wall oscillator devices, which many patients like, and which some of us will use on occasion. But the bottom line is, it really, as Dr. Daniels said, it's less important which you use, it's more important that you use it. So we try to have some guidelines. We try not to put people on therapy that they don't, see a benefit from or may not need. So who should use airway clearance? Now, this comes from the recently published European Respiratory Society guidelines just this past year. This is based on some of the published data, but a lot of it is expert opinion. So who should use airway clearance techniques? Again, patients who have symptoms, patients who have cough, patients who chronically produce sputum. Get that stuff out. Those who have difficulty expectorating sputum. I hear from my patients all the time, I have a cough, I have a rattle, I just can't get it out. These modalities will help you do that. Those who have impaired quality of life or frequent exacerbations, people like that should be on airway clearance measures. And again, the modality is less important. I pick the one that the patient tells me is most effective and the one that they're going to use. If you're not bought into it, you won't use it. So this is a very important discussion interchange between a provider and his or her patient. So let's talk about antibiotics. Now, when we talk about systemic antibiotics, again, we mean those that are taken by mouth or by vein. And that clearly has a major role in the treatment of these infections. So one of the general principles and important principles of approaching patients with Pseudomonas is that we treat these exacerbations aggressively. Sputum cultures are very important. Your doctor should be getting sputum cultures as best they can when you get sick. Number one, to prove or to document that this is Pseudomonas, and really to look at the sensitivity patterns. For patients who've been on repeated courses of oral antibiotics, we worry that those drugs won't be effective because the bug has developed resistance. It's important to know that. And every once in a while, and maybe more than every once in a while, it's a different bug. And you can use a more narrow spectrum antibiotic to treat a different pathogen. Now, as you know, quinolones like ciprofloxacin and levofloxacin are the only oral options. So we straddle the line for using them when we need to, but avoiding them when we could avoid them. Many of the exacerbations are viral and don't need antibiotics, and that really, again, is a very important conversation between you and your physicians to really make sure that you need an antibiotic. When you've had a number of courses of quinolones and there is antibiotic resistance, or if you have a severe exacerbations, IV antibiotics can be necessary, certainly dependent on the bug and the susceptibility patterns. But IV antibiotics, there are many options. So even if you develop a quinolone-resistant bug, thankfully, there are lots of intravenous antibiotics that can be used and can be used effectively. Now, how long should you be on antibiotics when you get an exacerbation? Well, that's, again, a matter of debate. The consensus that was reached by the European Respiratory Society is 14 days. The data suggests a minimum of 14 days, but longer courses, 21 or 28 days, can be necessary. So I will typically start at 14 days. We'll contact our patients, see how they're doing. If they're doing great, we stop. If they still have symptoms that are improving, then we'll go on to 21 and sometimes 28 days. So what's not appropriate in most circumstances is 2 or 3 days or 4 days of antibiotics. So most folks deserve a larger course and a longer course of antibiotics, which is different that we've done with the treatments of other infections where the course has been shortened. But bronchiectasis patients, for a number of reasons, will require longer courses of antibiotics. Now, the focus of the last several years has been on the use of inhaled antibiotics. And inhaled antibiotics have a number of really very attractive advantages. When you give a drug through the inhaled route, you get drug distributed in very high concentrations in the bronchial tubes. Now, we can't always know or tell where exactly they're going. They may be deposited in one lung versus the other, but in general, there's high concentration in the airway, and when you put a lot of antibiotic on top of bugs, it kills the bugs. When you give it inhaled, it stays primarily in the airways, and you get reduced absorption into the bloodstream, and we think that that reduces side effects and systemic toxicity because some of the drugs that we use when given intravenously can have systemic toxicity like renal failure, et cetera. So there are lots of advantages of using inhaled antibiotics. Now, there are some downsides, and one of those is that there are certainly adverse effects associated with anything that you inhale. So somebody mentioned before, I can't tolerate inhaled antibiotics. So we hear that, and these are symptoms like cough, like wheezing, like a change in voice and hoarseness, chest tightness. And these are actually pretty common. Typically, for some of the drugs, it starts 7 or 10 days into the course of therapy, and sometimes it actually necessitates stopping the antibiotic. Some people can fight through it, but on occasion we see that people just can't tolerate these drugs. And whenever we counsel patients and we start inhaled antibiotics, we have a discussion with our patients about what they could expect. The other issue, which I'm not going to get into, but which is really a concern for a lot of different people, is the emergence of resistant organisms. And again, that's a very complicated and actually very controversial topic that I won't get into here. The other important thing is that there's actually a long experience with inhaled antibiotics in cystic fibrosis. In fact, inhaled antibiotics are among the standards of care in patients with cystic fibrosis with Pseudomonas aeruginosa. The typical CF patient will develop Pseudomonas, chronic Pseudomonas infection early in life. And now there are 2 drugs, tobramycin and aztreonam, that have been studied, used effectively in patients with cystic fibrosis for a long time, and it has really changed in a good way the natural course of the disease. Now, one of the lessons I've learned in doing this work is just because it works in cystic fibrosis doesn't mean it works in other forms of bronchiectasis, and that's an important lesson. If I had given this lecture 10 or 12 years ago, I would have said one of the problems with inhaled antibiotics is that the techniques are cumbersome. To nebulize a drug takes a long time, and it's a pain in the neck. Well, it turns out that there are a number of new products out there that make the inhalation of antibiotics actually pretty simple and really of short duration. Now, there have been a number of guidelines that have been published about the use of inhaled antibiotics. So this is not just the United States. They're used clinically all over the world. I won't read all the conditions here, but both the Spaniards, the Brits, and our colleagues from Australia and New Zealand have come up with guidelines for the use of inhaled antibiotics. The common theme is not everybody with bronchiectasis should be or needs to be on an inhaled antibiotic. It should reserve for patients who have frequent exacerbations, and most often it's chronic Pseudomonas that we're treating in these circumstances. So the good news has been that there have been now a number of very well-conducted clinical trials for a number of aerosolized antibiotics up here that you'll see. So tobramycin, gentamicin, colistin, aztreonam, and more recently, 2 forms of ciprofloxacin. Now, each of these, again, these are very well-conducted studies. There are nuances to the ways the studies were conducted. So I'm just going to summarize the state of the art, and I don't want to be overly simplistic, but I really want to get in a limited time frame the information that I think is most important. There is no question that when an antibiotic is given in the inhaled route, that it kills bugs and it kills them very effectively. These are drugs that are commonly prescribed. If you look at our U.S. bronchiectasis research registry and you look at a subgroup of our patients who have 2 or more exacerbations a year, about 30% of our patients in the United States are on some kind of inhaled antibiotic. Unfortunately, though, the clinical benefit, which I believe is there, and I think my colleagues believe is there, has not been proven conclusively in research trials. And again, we can debate why that is, but unfortunately, none have been approved by regulatory agencies both in this country and abroad. Now again, we use these drugs, and we use them, again, specifically, and I'll tell you circumstances where I think they have the biggest role. Tobramycin and colistin are the most commonly used in the United States, and probably tobramycin by a large margin is the most common. But as you know, and as you may have experienced, they can be difficult to obtain, they can be expensive, and it takes a lot of convincing of third-party payers to pay for these drugs. And again, you don't want to use these injudiciously because adverse effects can occur and can be quite distressing to our patients. So when do we consider, or who do we consider for treatment with an inhaled antibiotics? Again, the themes are the same. Those with frequent exacerbations, we target more than 3. Some people debate whether it should be 2 to 3, but I think the data suggests that 3 is the right number. Clearly, the targeting is patients with chronic Pseudomonas, but other gram-negative infections like Stenotrophomonas or Achromobacter, other impactful gram-negative organisms can be responsive to inhaled antibiotics. And importantly, they should be used in conjunction with other treatment modalities like airway clearance and other things that we'll talk about to make sure that those are optimized. But there are lots of unanswered questions. Should you use them every day? Should you use them a month on or a month off? So again, I think we're going to need some guidance for clinical trials moving forward. I'm going to skip this for now. Now, there are other options as well, and I mentioned to you about macrolide antibiotics. So the macrolide antibiotics have been around for a long time, erythromycin being the one that you're probably most familiar with. And they're clearly very effective antibiotics, but they have a very narrow spectrum of action. And in fact, macrolides, if you put a macrolide on top of a Pseudomonas bug, the Pseudomonas will laugh at it. It's not effective. It's not a drug that's targeted to Pseudomonas. But these drugs have really amazing number of anti-inflammatory and immunomodulatory properties that may be very helpful in bronchiectasis. They help prevent biofilm formation. They help suppress some of the inflammatory pathways in patients with bronchiectasis, like Dr. McShane had mentioned. And they've been shown to be effective in other diseases of the airway, like cystic fibrosis, like COPD, and a number of other conditions that primarily involve airway and recurrent airway infections. So in terms of the information, this is a busy slide, but just know that there have been 3 trials that have been done over the last several years, each in which enrolled a different number of patients. They had a little bit of a different target population, anywhere from 1 to 3 exacerbations a year. 2 of them used azithromycin, 1 of them used erythromycin. The common endpoint to all 3 studies were looking at the reduction in the frequency of exacerbations, and luckily, all 3 studies reported a statistically significant, and we think a clinically significant, decrease in the number of exacerbations, and all 3 studies were published in high-quality medical journals. Now, the macrolides, again, are not devoid of problems. So one concern is the development of antibiotic resistance to the bugs that normally colonize our nose and our upper airway. These appear to be safe and well-tolerated in patients, but there's always a concern that a superbug that can threaten the general population will develop. Now, thankfully, we haven't seen it, but that certainly is out there, and there's surveillance that would be required. We've already talked about it, and Julie's already talked about this. If you use a macrolide antibiotic alone to treat non-tuberculous mycobacterial infection, that will oftentimes result in bacterial resistance, and we know that that makes that bug much more challenging to treat. So we really do not prescribe these drugs alone in patients who I know or who I strongly suspect has NTM infection. In patients who have underlying cardiac disease, particularly those that have rhythm disturbances in the heart, there can be some issues related to that. The risk is small, but again, I usually get an EKG on our patients and really take a history to make sure that they don't have advanced cardiac disease. And sometimes they're tough to tolerate. The GI tract and macrolides don't always get along well. So nausea, metallic taste in the mouth, some abdominal pain are frequently reported. And in long-term use, we always worry about the development of hearing loss and other complications regarding hearing. But again, I think in well-targeted populations, I think this can be a very effective treatment. So again, who do we target? Again, patients who have frequent exacerbations, more than 2 or 3 a year, and we specifically exclude those that have significant underlying heart disease or abnormal EKGs. We don't use these in patients with known or strongly suspected NTM infection. But again, there are some unanswered questions about macrolides, and that is, how long do we treat? Do we treat for a year? Do we treat for 2 years? Do we keep going? So those are unanswered questions, and this is really a personalized decision based on a conversation between the physician and his or her patient. Now, so what do? You have inhaled antibiotics and you have macrolides. And I don't know what the right answer is. In general, there appears to be the most preponderance of evidence thus far is for macrolides. So I think it certainly makes sense in patients who have bronchiectasis, who have Pseudomonas infection, and who have frequent exacerbations to start macrolides if there are no reasons why you absolutely shouldn't be on it, and if you can tolerate it. And we typically will use azithromycin And because it has a long half-life, that means it hangs around not only in the bloodstream, but it hangs around in the lung for an extended period of time. We use it 3 times a week, and I will typically use it 500 milligrams 3 times a week. I don't use it in patients who have co-infection or strongly suspected of having co-infection with MTM. Patients with significant heart problems or who have impaired hearing, I use it with a lot of trepidation. Now, I work in southeastern Pennsylvania, and Dr. O'Donnell mentioned it, that's one of the hotbeds of NTM. So unfortunately, the number of patients that I can use this drug in is relatively limited. So we oftentimes need to turn to inhaled antibiotics, either when we've tried a macrolide and it didn't help, it didn't reduce exacerbations, or if there are reasons why we can't use macrolide antibiotics. We certainly need more data about the role and the coexistence of these two modalities in patients with Pseudomonas infections. Now, this is a little bit of a busy slide, but this is what our colleagues from Europe have recommended. This was published again last year in the European Respiratory Journal. Again, this is what they call a conditional recommendation. That is, it's made really based on expert opinion in the setting of low evidence that's published in the literature. So again, they agree they target patients who have more than 3 exacerbations. Again, it goes without saying that folks should have their treatment otherwise optimized, like airway clearance, treating their underlying causes. If you have Pseudomonas, they recommend starting with a long-term inhaled antibiotic. If there's no response or intolerance, then switch over to a long-term macrolide therapy. If you get an inadequate response, they recommend that you consider using both. So again, there's different approaches to this, but understand that there are armamentaria that can be helpful in patients who have chronic Pseudomonas infection. But as I mentioned before, again, this is more than just drugs, more than about antibiotics. When an underlying cause is identified, the treatment of that underlying cause can be very, very helpful. You've heard again about the impact of exercise and pulmonary rehabilitation. Exercise is good for you, folks. It's good for your heart, it's good for your lungs, it's good for muscle function. It really is a very important part of a comprehensive treatment regimen. Oxygen for people who need it can be very important to stave off complications of low blood oxygen, including cardiac problems. Ensuring good nutrition is critically important. One of our patients mentioned weight loss, and that's certainly something we pay attention to. And again, getting a good nutritional plan, working with a good nutritionist is critically important. And then there are some patients, I don't want you walking out of here thinking that surgery is a major part of the treatment of bronchiectasis. But for some patients, particularly those who have localized disease, either NTM or garden variety bronchiectasis, who have recurrent exacerbations and who are failing medical therapy and who have adequate lung function, we know that surgery can be done with acceptable morbidity and really very low mortality in very selected patients. So, probably in my whole panel of patients, I probably have had 4 patients who have undergone surgery, but when well selected, again, it's potential part of the treatment of bronchiectasis. So in summary, it's not just about antibiotics. Comprehensive treatment, including airway clearance, is important. Antibiotics, systemic antibiotics, are very important for treating acute exacerbations, and I've spent a fair amount of time talking to you about inhaled antibiotics and chronic macrolides. And again, we're not done. The good news is that I think we're at the dawn of a new day in bronchiectasis and NTM research, and if you spend any time at this conference, you see the exciting developments that I think the next few years are going to show that will come to fruition. So I congratulate you for being here. For those of you who participated in clinical trials, thank you. And as we move forward, please consider that as part of your treatment is to consider clinical trials along with your physician colleagues. So thank you very much and safe travels home.
Any questions for Dr. Tino?
You mentioned biofilm, and I think in the next decade that's going to be a huge focus about that. I'm a teacher of English, I'm not an MD, but I've heard it often enough so that biofilms are keeping antibiotics from affecting these bacteria. Have you heard of using colloidal silver to help break down the biofilms along with the antibiotic?
So the answer is I've heard of it. I have no experience, and we have really little data. I don't know what these guys think. Now, but your point's very well taken. You know, there have been some attempts, these liposomal preparations. One of the advantages may be that that these, because of the way the antibiotic is packaged in these liposomes, these little fat bubbles, that it may make it more effective to get through into the bacteria. But I agree that that's true of a lot of other infections as well, including bloodstream infections related to catheters. A whole host of human infections really have biofilms as an important bad partner. But thank you.
I haven't so far heard guaifenesin mentioned either as how effective it might be or whether it could cause dangers like to the kidney or liver.
So the question was about guaifenesin. So the reason you haven't heard about it is because we really just don't have any data for it, but it's very commonly used. I mean, it's Robitussin, essentially. So Robitussin is basically guaifenesin, and it has some intrinsic properties, and some people find it very helpful. And when used judiciously, I think it's actually quite safe. So if it works, again, it's that same theme of if you find something that's safe and it's effective and really makes you use it on an ongoing basis, then I think that's fine. Yes?
So I remember hearing you saying that the Pseudomonas, it can travel to the nose and the upper airways. That's what I've been experiencing lately. And then it changes into like Haemophilus influenza also. Is that also like a type of negative gram?
Well, there's a whole, so there are bacteria that are very common in bronchiectasis patients. So Pseudomonas is one of those. Haemophilus influenza is a different bacteria, and it's a very close second in terms of its commonality in patients with bronchiectasis. But therefore, there's a laundry list of potential bacteria, but the most common are in fact Pseudomonas and H. flu. And they don't transform from one to the other. They're different bacteria and have different characteristics.
I was going to ask, what are some of the exciting breakthroughs that you referenced? I know that was part of the agenda for the doctors, but for the patients.
So there's a number of, Dr. Chalmers really had a wonderful slide as part of his last talk yesterday, so along a number of levels. Certainly there are a number of anti-inflammatory drugs that are in preparation or at least are in development that we hope will go on to early stage clinical trials to prove safety before we go on to efficacy. There's some research on statin drugs, for example. I think we all should be on statins for something or other. Certainly, I think there are other antibiotics. So colistin is now being studied, both actually international study, looking to follow up on a study that was published from the UK several years ago. So we've got antibiotics, anti-inflammatory drugs, and I think as we learn more about how bronchiectasis develops and what the key features are, I think we can get some more targeted treatments.
Thank you.
Yes.
I'm from Philadelphia.
Go Eagles!
I've been here since '66, and I think back to some of the things that occurred. But what is it about Philadelphia that makes it a place where there's a high incidence of this disease?
I'm gonna use a football reference. I'm gonna punt this to somebody else. So Anne, Dr. Casper Bauer back there.
We're going to discuss. We'll discuss that
Yeah,
in a minute.
it's a great
'cause
question.
We have
It's a great question.
experts to discuss that in a minute. Okay. One more question.
You mentioned good nutrition, and I've read that certain foods produce a lot of mucus and they should be avoided. What are your thoughts on that?
So that's a good question. Somebody asked me that the other day, and I used to say that milk products, a lot of dairy products have people overproduce mucus, and we used to at least caution patients against it. I'm not sure that's actually true. Do you know of any? So
I was going to say, I haven't, I've heard patients say that, but I haven't seen the data to back it up. I've had one patient who, we actually did a food allergy panel on him, and when it was positive and he restricted that particular food, his mucus did decrease. But if you don't have a true allergy, and particularly for milk and dairy and decreased bone density, which we do see an increase of in our postmenopausal women, I wouldn't advocate on restricting it empirically with the hope that it would improve your mucus.
okay, thanks, folks.